lipidemia. Now, cholesterol and triglycerides have some very beneficial functions in the body, and it's important to realize that all of your cells produce cholesterol. We need cholesterol so that the walls of the cell function and are pliable. And cholesterol is also involved in the production of hormones like estrogen and testosterone, cortisol, which controls the inflammatory process, and aldosterone. It's also needed to produce vitamin D and to produce the myelin sheath on the nerves so that nerve impulses can be conducted. Triglycerides are made by the liver, and we store these triglycerides in case we need a source of energy we have not eaten. Excess calories, generally carbohydrates, are converted to triglycerides and stored in cells. Lipoproteins are made by the intestine and the liver, and they contain cholesterol, triglycerides, and protein. Their function is to transport fatty acids to storage for when we need them for energy. HDL is called the healthy lipoprotein. It is a high-density lipoprotein, and it actually carries cholesterol to the liver so the liver can make bile. And then that bile is excreted in the intestine. LDL is low-density lipoprotein, or lousy lipoprotein. It actually begins as VLDL. Once that VLDL releases its fat, it becomes low-density lipoprotein. That low-density lipoprotein carries fat to peripheral tissues like the skin and to your arteries. Atherosclerosis begins when macrophages, or white blood cells, migrate to the arterial wall to try to remove some of this excess cholesterol. When these white blood cells engulf that cholesterol, they form foam cells. These foam cells set up a chronic inflammatory process. Because of this inflammatory process, smooth muscle cells migrate to the arterial wall. And proteins secreted by these smooth muscle cells actually form a fibrous plaque. But those dead foam cells inside that plaque can cause it to weaken and rupture. When that happens, platelets rush to the area and a clot forms. This is why someone has a heart attack or a stroke. There are many theories about why atherosclerosis develops. The first is that uncontrolled hypertension damages those delicate endothelial cells lining the inside of the blood vessel, and that starts the inflammatory process. Another theory is that pathogens infect the endothelial cells. That produces free radicals, and again, we have the inflammatory process set up. Another theory is that serum iron, if the levels are too high in the blood, this iron oxidizes, again producing free radicals and starting the inflammatory process. Patients with diabetes also have a higher risk for atherosclerosis because they have high levels of triglyceride and cholesterol in their bloodstream. That leads to poor circulation. The cells cannot get enough oxygen, and so those inflammatory processes begin in the endothelial cells lining the blood vessels. There is some controversy about whether serum homocysteine is the cause of atherosclerosis. Now, we know that serum homocysteine is an amino acid metabolite, and it also causes endothelial cell damage like the other factors I've mentioned. When this endothelial cell damage occurs, it causes clotting factors to malfunction, and it oxidizes low-density lipoprotein. That again causes the inflammatory process. We diagnose atherosclerosis by cardiac imaging. We can actually pick up plaque deposits when we do this type of imaging. Now, we would like your serum cholesterol levels to be below 200 milligrams per deciliter. We have found that if people under the age of 30 have a cholesterol level above 180, that actually increases their risk of atherosclerosis. When you do your assessment, you're going to be able to tell if a person has high serum cholesterol without looking at labs. Xanthomas are yellow nodules that contain cholesterol. Remember, the cholesterol is carried to the skin and stored, and that's what you see in these white plaques around the eye. And also, notice the whitish blue ring around this person's eye. That also suggests a high serum cholesterol level. When you do your assessment, you're going to ask your patient about their health history, including a family history of high cholesterol, their diet history, and if they do any exercise. Now, it's important to note that there are some people who have a low-fat diet and exercise, but they still have a high cholesterol level because their liver is producing too much cholesterol. Remember that cholesterol is needed by every cell. We have lipid-lowering agents that we can give to lower serum cholesterol, but if somebody eats a high-fat diet, it's going to cancel out the good effects of these lipid-lowering agents. Our pediatric patients are developing atherosclerosis at age 10 or younger. And this is because of the obesity epidemic, the reliance on fast foods, which elevates cholesterol levels, and because children are developing hypertension, both because of obesity, because of the amount of salt in their diet, and so forth. Also, children who are exposed to cigarette smoke have increased fatty acid streaks in their arteries. Niacin, or nicotinic acid, actually lowers the concentration of free fatty acids so that less triglyceride and VLDL is produced. Niacin also increases the good type of cholesterol by 15 to 35%, while decreasing triglycerides by about a quarter. We have found through research that if we give statins, which we'll talk about in a few minutes, and niacin, that we can reverse carotid artery atherosclerosis. We can clear up those carotid arteries. If we give bile acid sequestering agents in niacin, then we can help clear up the plaque development in coronary arteries. Niacin is very inexpensive, but because of intense flushing of the skin, the arteries dilate and it makes you feel very warm and you get beet red. And it causes itching. People stop taking niacin. But if we give them aspirin or ibuprofen before the niacin, then this flushing and itching is decreased greatly and they can tolerate the medication. Now, because there is a dilation of blood vessels, which is a transient effect of this niacin, they can develop hypotension and feel dizzy and lightheaded. In order to encourage people to take niacin, we have different types of niacin that we can give them. We can give them immediate release niacin, in which all of the med is released at once, or we can give them extended release niaspan, and it slowly releases niacin over an 8-hour period, or we can give them sustained release niacin called slow niacin, and that is absorbed over 12 to 24 hours. So they don't get this flushing effect with either extended release or sustained release, and they can tolerate the medication.
Fibrates like gemfibrozol reduce liver triglyceride production by decreasing free fatty acid use by the liver. The liver needs to use free fatty acids in order to make triglycerides. Fibrates also decrease very low density lipoprotein by inhibiting the synthesis of apolipoprotein B and increasing its clearance. Without apolipoprotein B, VLDL production is decreased. When a patient is on a fibrate, you must teach them that they have to have their liver function test monitored on a regular basis as prescribed by their healthcare provider. Fibrates also can increase the effectiveness of anticoagulants, so you have to watch your patients for bleeding. Common side effects from this class of drugs are mainly GI distress, but it can cause inflammation of the muscles and it can cause liver inflammation.
So there are two fibrate meds that you're likely to see on clinical. The generic name for the first one is fenofibrate, and you see all of these trade names. Tricor is the one I've seen used most often in clinical. And then gemfibrozol, or Lopid, that's also seen commonly in clinical. Both of these medications are fibrate medications. Bile acid sequestering agents like Questran bind with bile acids in the intestines, so these bile acids are excreted. We need bile acids to absorb fat from food because it helps to emulsify fat. Because we're excreting these bile acids, the body then breaks down cholesterol to form more bile acids, so that in effect lowers our serum cholesterol level. These bile acid sequestering agents can come in a pill form, powder, or granular form. The powders and granular form have to be mixed with water. The side effects are mainly GI, with constipation, bloating, heartburn, and nausea. Because these bile acid sequestering drugs decrease folate levels, we need a supplement. We also need a supplement of all fat-soluble vitamins A, D, E, and K. You give these drugs 1 to 2 hours before other medications or 4 hours after other PO medications in order not to affect absorption of the meds.
HMG-CoA reductase inhibitors are commonly called statins. HMG-CoA reductase is an enzyme that the liver needs in order to produce cholesterol. It takes 1 or 2 weeks of being on the medication for lab results to begin to show a decrease in the total cholesterol level, and the peak effect is reached in about a month to a month and a half. It is important to administer statins in the evening because that's when the liver produces most of the cholesterol.
We have found that the statins improve endothelial function. They return the health of those endothelial cells. It increases our healthy, or HDL, while lowering our LDL and VLDL. It also inhibits our platelets from sticking together, so hopefully those clots will not form in the arteries in the brain or the heart. And it reduces inflammation because it reduces the C-reactive protein level. And remember, our C-reactive protein is one indicator of the inflammatory process. When you take a statin, you need frequent liver studies done. We start out by doing it every 3 months and then go to every 6 months because these statins can cause severe liver damage. We have the usual GI upset, constipation, diarrhea, headache, and myopathy, which is muscle weakness and muscle pain or myalgia. Rhabdomyolysis is a very dangerous adverse effect of statins, and you need to know this. In rhabdomyolysis, the muscle fibers actually break down. As these muscle fibers break down, they release myoglobin into the bloodstream. This myoglobin can put someone into acute renal failure. In order to determine if a person has rhabdomyolysis, we do a blood test called serum creatinine kinase, or CK, and that will pick up damage to muscle cells. Ezetimibe, or Zetia, belongs to a class of medications called cholesterol absorption inhibitors. This med actually stops cholesterol from being absorbed in the intestine from the food that you eat. It does not inhibit cholesterol synthesis in the liver, and it does not increase bile acid excretion. Now, side effects can occur, and they can be GI, severe diarrhea being an example, or myalgia, which is muscle pain, rhabdomyolysis. This class of medication can also cause severe inflammation of the liver and pancreas, and a reduction in platelets called thrombocytopenia. We get our source of omega-3 fatty acids from the food that we eat. For example, fish, shellfish, basil, spices, spinach, nuts, and so forth. An intake of omega-3 fatty acids from cold water fish can actually reduce your triglyceride level by up to 50%. Because it reduces hepatic triglyceride production, and it promotes the clearance of excess triglycerides from your bloodstream. If someone is not getting enough omega-3 fatty acids in their diet, we can give them a fish oil supplement. A common one that we use is Lovasa. They have to notify the prescriber if they are allergic to fish or shellfish. Some side effects include more frequent burping or eructation. It can change the taste of some food and cause nausea. But this fish oil is a supplement.
There is a new class of medication to lower cholesterol, and these medications are called PCSK9 inhibitors. Evolocumab or alirocumab. They were just approved in July 2015. The action is to make more low-density lipoprotein receptors available to clear low-density lipoprotein from the blood. These low-density lipoprotein receptors are found on liver cells, and they clear low-density lipoprotein from the blood, which lowers cholesterol. The better these receptors function, the more low-density lipoprotein we can get from the blood. PCSK9 is actually proprotein convertase subtiliskin kexin type 9, which is a protein. It binds to these LDLR, or low-density lipoprotein receptors, on the liver cells, causing them to break apart. Once these receptors break apart, they can no longer clear LDL from the blood. Alirocumab is an example of one of the PCSK9 inhibitors. It prevents PCSK9 from binding to the low-density lipoprotein receptors, so they're not destroyed. So the easiest way to think about it is alirocumab actually keeps the low-density lipoprotein receptors functioning because they're not broken down by this PCSK9 protein. Alirocumab is used when diet or statin therapy at the highest safe dose of statins is not able to reduce the patient's cholesterol. Some patients have too high of a cholesterol output by the liver because of a genetic malformation. Patients who also have atherosclerotic cardiovascular disease and who require additional lowering of their low-density lipoprotein are candidates for alirocumab therapy. The medication has not been used widely enough and long enough so that we can say what the effect on morbidity or mortality from cardiovascular disease is yet. The medication is given sub-Q every 2 weeks, and depending upon the dose, the cost can equal up to $15,000 a year. The medication is covered by most insurance. Alirocumab is usually given with a statin, and you can see that the half-life is very long. It's about 12 days. The healthcare prescriber will want the patient to go to the lab to have their LDL-C tested 1 to 2 months after starting the medication. Some of the side and adverse effects include allergic reactions, as with all drugs, and vasculitis. And here you have a picture of a patient who has vasculitis. The most common side effects to date are just a feeling like you have a cold, or you may have the flu, or the injection site becomes red and painful. Some of the people who have taken alirocumab have had some confusion and memory loss, and some have had elevated liver enzymes. So we need to check their liver function also. And again, the clinical trials are continuing even though the drug has been approved for use, because we don't know how successful alirocumab is going to be in preventing heart attacks and stroke. There are some very specific administrative guidelines that you have to follow. The client has to be taught that they will have their LDL cholesterol level checked 1 to 2 months after starting the med or changing the dose of the med. If they miss a dose and it is within 7 days of when they were to take the dose, then we instruct the patient to go ahead and take that dose and resume the original schedule. If the missed dose is 7 days or more from the time when it was supposed to be taken, then they just wait until the next dose. Remember, they take this medication sub-Q every 2 weeks. Alirocumab is kept in the refrigerator, and you must warm it to room temperature by removing it from the refrigerator for 30 to 40 minutes before it's injected. Do not leave this drug at room temperature. It degrades and it cannot be used. And remember, it costs $1,100 a month, so you don't want to be throwing this medication away just because you forgot to keep it in the refrigerator. We give the subcutaneous injection in the thigh, abdomen, or upper arm, and the medication comes in a pre-filled pen, and some come in a single-dose pre-filled syringe. The injection site has to be rotated with each injection, and do not inject it into skin areas where there is active skin injury, such as a sunburn, or skin disease, such as a rash or inflammation or an infection. And it cannot be mixed with other injectable drugs and given at the same injection site. So keep it in the refrigerator, take it out of the refrigerator 30 to 40 minutes before use. Make sure that you rotate sites. Do not inject it if there's skin injury or disease, and do not mix it with a syringe containing other medication or give it in the same site as another medication.
General interventions for your patients that are receiving drugs to lower cholesterol include diet teaching, because many people do not understand which foods are high in cholesterol. And this is a long-term therapy. For most of the drugs, they have to go back for follow-up labs, and they have to make permanent lifestyle changes. These meds that can cause constipation require the patient to increase fluid and fiber in their diets. Caution your patient about orthostatic hypotension if they take immediate release niacin. And remember that giving one aspirin tablet about 30 minutes before niacin will stop that rapid release of histamine, which causes the flushing. Now again, this flushing only lasts for maybe 10-15 minutes, but it's very annoying to patients. For medications like statins or any medication in which we have to monitor liver function, stress the importance of reporting to their healthcare prescriber if they notice signs of jaundice, if the whites of their eyes are getting yellow, if their skin looks like it's beginning to take on a yellow tinge, they have to report this immediately. Now the bile sequestering agents like Questran, they actually cause a decrease of fat-soluble vitamins A, D, and K. So if your patient is on a bile sequestering agent, make sure the healthcare provider also orders a vitamin supplement that contains vitamins A, D, and K. These are the guidelines that cardiologists and other physicians will follow related to cholesterol, LDL, HDL, and triglyceride levels. You can see from the chart that the total cholesterol level is optimal when it's below 200 milligrams per deciliter. If it's above 240 milligrams per deciliter, then it's considered very high for a total cholesterol reading. The HDL cholesterol, remember, we want that to be high. So in both men and women, if we can get the HDL 60 or above, that is fantastic. If not, we try to have men have an HDL cholesterol level at least between 40 and 49. And in women, we want it a little higher. We want it between 50 and 59. The LDL cholesterol, most physicians want it to be below 100 milligrams per deciliter if the person has heart disease. If you don't have heart disease, then an LDL cholesterol between 100 and 129 milligrams per deciliter is fine. Once it gets to be above 160 milligrams per deciliter, it is considered high. For triglycerides, we hope that clients will have a triglyceride level below 150 milligrams per deciliter. If it gets up to 200 milligrams per deciliter and above, then that is considered high. So again, total cholesterol should be below 200. HDL cholesterol, ideal is 60 or above. LDL cholesterol, below 100 is ideal, or if you don't have heart disease, 100 to 129. And triglycerides, below 150 is what we are aiming for. I am now going to talk about angina. One of the main reasons why angina occurs is because of atherosclerosis. A person with angina has narrow or stiff coronary arteries that do not dilate in response to increased oxygen demand, such as during periods of exercise. Because the cells cannot get an adequate oxygen supply, anaerobic glycolysis takes place, and that causes a buildup of lactic acid, which irritates nerve endings and causes pain. In cardiac muscle ischemia, there is simply an imbalance between how much oxygen the heart muscle needs to perform and the supply of oxygen coming through the coronary arteries. It's a warning sign that a heart attack may take place. The pain of angina is generally less intense than the pain of an MI or heart attack, and many people say it's a gnawing sensation. Always ask your patients to describe the discomfort or pain that they are feeling. The cardiac muscle, as you remember from biology, is perfused during diastole or between beats. And the amount of oxygen the heart muscle needs is determined by the heart rate. The faster the heart rate, the more oxygen the heart muscle needs. Contractility, how forcefully those ventricles contract. The more force they have to push against to get blood out into the pulmonary artery or the aorta, the more oxygen that heart muscle needs. And it's also determined by preload and afterload. Whenever cardiac output falls, the sympathetic nervous system is stimulated. When the sympathetic nervous system is stimulated, remember it causes peripheral vasoconstriction, increased contractility of the ventricles of the heart, tachycardia, and also restricts renal blood flow by partially constricting the renal arteries. All of this is an attempt to overcome that decreased cardiac output, but in fact it makes it worse. There are several types of angina that you may read about, and you will see these identified in your patient's chart. Prinzmetal's angina is also called variant angina. It occurs when the patient is not doing anything strenuous. They often wake up at night experiencing that pain. Prinzmetal's angina is caused by a spasm of the coronary artery. Very often the patient with Prinzmetal's angina has an abnormal heart rate or dysrhythmias. The pain from Prinzmetal's angina usually lasts about 5 minutes and is unrelieved by rest because the patient is already at rest when this coronary artery spasm begins. Stable angina is also called classic angina. This is when the patient does not have chest pain during normal activity, but anytime there's any stressful activity, such as walking up a flight of stairs, the coronary arteries cannot deliver the amount of oxygen that the heart muscle needs, and the patient experiences pain. When the activity stops, the pain stops. There is also silent angina. This is because the nerves that would sense the pain have been damaged, and we see this in our patients who have diabetes. And then there is unstable angina. That's a combination of classic or stable angina and variant or Prinzmetal's angina. And this is a very dangerous type of angina because the pain is felt during both rest and activity, and it means that the heart muscle is not able to get enough of a blood supply. The treatment for angina focuses first on having the patient stop smoking if they do smoke, because nicotine is a potent vasoconstrictor. Reducing weight if they are obese, lowering their cholesterol level by diet and exercise, and control of hypertension. All of these things will help relieve some of the stress on the heart. For your assessment, you're going to monitor vital signs. You have to obtain vital signs when the patient is admitted, and anytime they're having chest pain, you need to assess their vital signs. You're going to monitor for complaints of chest pain and relief of that pain. We have several drugs that we can use to help manage angina, and the therapeutic outcomes that we're trying to achieve are a decreased oxygen demand on the heart muscle. We're going to do that by lowering blood pressure, lowering blood volume if the patient is retaining fluid, and slowing down the heart rate. And we're going to try to increase the blood flow to the heart muscle itself through the coronary arteries. Both of these things should decrease the incidence and severity of angina. Now, we have medications that will stop an episode of angina once it has started, or meds that can decrease the frequency of these episodes. Beta blockers are used to help relieve angina by reducing the workload of the heart. They do this by lowering the force of contraction of the ventricles. This means that the heart muscle itself needs less oxygen. They also lower heart rate. The slower the heart beats, the less oxygen the heart muscle needs. So cardiologists have established a goal of an apical rate between 50 and 60 for a patient taking a beta blocker to relieve angina, and they will write that parameter on the order for you. Beta blockers also reduce vascular resistance because they allow the blood vessels to dilate. Calcium channel blockers are also used to relieve the oxygen demands of the heart. They dilate arterioles, including coronary arteries. They dilate peripheral blood vessels so that the left ventricle does not have to work so hard to get blood pumped out to the system. They decrease the heart rate and contractility just like the beta blockers do. Another class of med that we can use to treat angina is the partial fatty acid oxidation inhibitor, ranolazine. We're not really sure how it works, but this is the latest theory. The latest theory postulates that this medication stops the flow of excess sodium into cardiac cells when the heart muscle is undergoing ischemia. By stopping the excess flow of sodium into those cardiac cells, we also reduce the amount of calcium entering those cardiac cells. That means that the strength of the heart contraction will now be lowered and the cardiac muscle can relax. So this then will relieve the pain of angina. It does not affect blood pressure or pulse. Nitrates have been used since the late 1800s. They are very fast acting. They dilate both arterial and venous smooth muscle of blood vessels so that we have a reduction in both preload and afterload, and a reduction in the amount of oxygen that heart needs. Side effects of nitrates are a headache. When a person is first started on nitrate therapy, they're going to complain of a severe headache, but the longer they take the nitrates, the less severe that headache becomes. Because it helps dilate blood vessels, they can also have orthostatic hypotension. And because it's dilating blood vessels and reducing preload, there may be a slight decrease in cardiac output, so then reflex tachycardia takes over. Now, in order to counteract that reflex tachycardia when a person is on a nitrate, the nurse practitioner or physician may order a beta blocker or a calcium channel blocker. There are some precautions that you must teach your patients about if they take nitrates. The first is that they cannot just automatically stop taking the nitrates if they have been on it for a period of weeks or months, or sometimes patients are on it for much longer. Because if they just stop taking their nitrates, then their coronary arteries may go into spasm, and that can cause a heart attack. For our male patients, we teach them not to take nitrates with alcohol or erectile dysfunction meds like Viagra, because that combination will cause a very low blood pressure that can result in a heart attack and death. There are many ways that your patients can receive nitroglycerin. It can be in a small tablet they put under their tongue. It can be in a tablet that is given orally, a slow-release capsule, intravenously in the ER or coronary care unit. You can give it as a patch, a cream, or a spray. They spray it under their tongue. Very often you will see an order for nitro paste on the patient's chart, and they will order it in inches. And I've given you here an example of the nitro bid paper. You can see how it is calibrated in inches. So you would squeeze the nitro paste onto the nitro bid paper It either squeeze on an inch and a half, 2 inches, or just a half an inch, and that is how the patient gets their dose. This nitropaste is usually changed every 6 hours. Now on the bottom you have a picture of a nitro patch. We generally put that on in the morning and take it off in the evening. And the reason we take it off is if the patient has stable angina, they do not need nitro during their time of sleep. And we take it off at night so they will not develop a tolerance to the medication. Now remember that once you put that nitro dur patch on, or the nitro paste, it's going to take a half hour or an hour before that's absorbed into the system and they start getting the effects. Sublingual nitrate, you can see how small those tablets are. You teach the person that at the beginning of an angina attack, they're going to put 1 tablet under their tongue. It takes 1 to 3 minutes before they get pain relief. You leave this nitro in a labeled bottle at the bedside. If those nitrate tablets are exposed to air, heat, or light, it can deactivate the nitroglycerin. So they have to replace those tablets every 3 months and keep them in the original bottle because that bottle is a brown colored bottle, so light can't get through it. Now there was research done in 2009 and they studied 346 patients who carried sublingual nitroglycerin. 23%, almost a quarter of those whose tablets were older than 1 year, and 15% whose tablets were 7 to 12 months old had low potency tablets when they tested them, meaning that if they had needed them in an emergency, they might not have gotten the relief that they were expecting. Nitro Mist is relatively new on the market. It delivers the same dose as a sublingual nitroglycerin tablet, and you can see here that it's sprayed under the tongue. That spray bottle has to be reprimed once every 6 weeks if they haven't used it, so they just have to push the plunger down and spray the nitro into the air. When they're using the nitro mist for relief of angina pain, it's important that they do not swallow it, that they do not spit or rinse their mouth out for 5 to 10 minutes after using the spray. And you tell them not to shake that container because it may cause air bubbles to form. So instead of getting the full dose of the medication, they would get a lesser dose. The emergency care for angina is the patient will take 1 nitroglycerin tablet, wait 5 minutes. If the pain is still there, take another nitroglycerin tablet. If the pain is still there, take a 3rd nitroglycerin tablet after 5 minutes. So you're going to take 1 nitroglycerin tab placed under the tongue, 1 every 5 minutes times 3. If the pain still persists, they need to get to the emergency room right away. Now we're going to practice some EKGs again. We're going to look at atrial rhythms. When your client has a dysrhythmia, your priority nursing diagnosis is high risk for or actual decreased cardiac output related to conduction deficits. They may have pain related to decreased cardiac output, anxiety related to the pain, decreased gas exchange because of a decreased cardiac output, and high risk for injury because of the medications that we may have to give them. There are many causes of dysrhythmia. In the hospital, you will most often see it because of electrolyte imbalance, too much or too little potassium or magnesium, or because of heart damage from an MI, or medications that we give the patient such as digoxin, which we'll talk about next week, beta blockers, and calcium channel blockers. Anything that causes hypoxia or a decrease in oxygen in the bloodstream may cause a dysrhythmia. And we've talked about recreational drugs such as cocaine causing severe hypertension can also cause a dysrhythmia. Now, caffeine, nicotine, or alcohol in large amounts can also cause an irregular heartbeat, as can anxiety and coronary artery disease, which is abbreviated CAD. When you see the term bigeminy used on a patient's chart, it means that every other beat is abnormal. Trigeminy means every third beat is abnormal, and a couplet means that two beats that come together are both irregular. The sinus node gets its blood supply from the right coronary artery and the left circumflex artery. If those are damaged because of a heart attack, then the sinus node will not be able to perform as expected. The sinus node is also innervated by the vagus nerve, parasympathetic nerve, and several sympathetic nerves. If there's vagal nerve stimulation, it's going to slow down heart rate. When you have a sinus dysrhythmia, it means that the SA node fires in an irregular fashion. Now, this is normal in athletes, small children, and elders. Many people have a sinus dysrhythmia, but it does not cause concern if it is asymptomatic. However, if you have a patient that is on the medication digoxin, and they suddenly develop a dysrhythmia, you have to call the healthcare provider immediately. On the top strip, I've shown you what normal sinus rhythm looks like. You can see the P wave, and then the QRS, and then the T. And this configuration is all the way across the strip. The middle one shows you sinus bradycardia. It is still a sinus rhythm, but it is at a much slower rate. And the bottom one tells you the criteria for diagnosing sinus bradycardia. The heart rate has to be below 60, but the rhythm is regular. There is a P before each QRS. That PR interval that we talked about is 0.12 to 0.20 seconds, and the QRS is shorter than 0.12 seconds. Sinus bradycardia, again, is common in athletes or after an MI, and also during sleep. If we do not have any symptoms from sinus bradycardia, we do not consider it a problem because cardiac output has been assessed. Always assess for cardiac output. If the patient develops hypotension and dizziness, that is a sign that cardiac output is not sufficient to meet the demands of the body. For sinus bradycardia, always assess the serum digoxin level and potassium levels. The treatment for sinus bradycardia is atropine because that increases your heart rate. Some patients may need a pacemaker, and the doctor or nurse practitioner may stop digoxin, beta blockers, or calcium channel blockers because all three medications slow the heart rate. The top EKG again shows you that normal sinus rhythm, and the middle one now shows you sinus tachycardia. The rhythm is still normal and regular, but it has sped up to above 100 beats per minute. There is a P before each QRS, and the configuration looks identical all across the strip. The PR interval and QRS interval are within normal parameters. There are many things that can cause an elevated heart rate. What you're going to see most often in acute care settings is that pain and fever will increase the heart rate, as will stress and anxiety. Now, if the client develops congestive heart failure, or they go into shock, if they have pericarditis or blood clot to the lung, if they're septic because of an infection, or if they have hyperthyroidism, they will also have sinus tachycardia. You notice all of the meds that can cause tachycardia: alcohol, caffeine, nicotine, atropine if we give too much, aminophylline, which we'll talk about when we do the respiratory section, and dopamine and epinephrine. All of these can cause tachycardia. To treat sinus tachycardia, we're going to give medications that are going to slow the heart rate. So we can give a beta blocker or a calcium channel blocker. We want to slow the heart rate enough to maintain good cardiac output, because when the person has tachycardia, there's not enough fill time between depolarizations so that cardiac output is decreased. Now, if you're taking care of a patient who has had a heart attack and they have a sudden onset of tachycardia, call the nurse practitioner or physician immediately, because that may mean that the area of damage is increasing. The top strip again is your normal sinus rhythm, a P, Q, R, S, and T configuration. The middle one is sinus pause, also called sinus arrest. If you start at the left-hand side, you have a P, Q, R, S, and T, P, Q, R, S, and T, and then nothing. And then another P, Q, R, S, and T. So we cannot do a rapid identification of heart rate because the heart rate is too irregular. The rhythm is very irregular. There is a P wave before each QRS, but then there's an absence of a PQRS and T, one or more. Now the PR interval and the QRS are within normal limits, but it is just as if the heart has forgotten to beat. Increased vagal nerve stimulation from the Valsalva's maneuver, for example, bearing down when you have a bowel movement, or carotid sinus massage or vomiting can cause that sinus pause and arrest. It is vital that you understand that only a doctor can do a carotid massage. Now, meds that commonly cause a sinus pause or sinus arrest are digoxin, quinidine, aspirin when it's toxic, and beta blockers. Coronary artery disease, hypertension, and an acute inferior wall MI are also reasons that the patient might develop a sinus pause or arrest. When you sleep, you may have a 2 to 3 second pause, and that's perfectly normal. If it is a second pause, the person probably will faint. We treat a sinus pause and arrest the same way as we treat severe bradycardia, and we may have to put a pacemaker in.